So I'm Dreyen, I'm one of the consultant urologists here in ILUTS25, and I subspecialise in BPH and endourology, mainly minimally invasive surgical techniques under local anaesthetic, as well as holmium laser enucleation of prostate and green light laser prostatectomy. Specifically for water vapour therapy, we offer it to men under local anaesthetic who have a prostate gland size of around 40 grams up to around 80 grams, who are looking to preserve their sexual function. We also offer it to some men who are not suitable for general anaesthetic, who might be too frail to be listed in theatre, and we offer them this as an alternative. We have a large number of patients with obstructive urinary symptoms and even urinary retention who are waiting months to be seen and potentially years to have treatment for a problem that is solvable within a few minutes. We have the infrastructure here to deliver local anaesthetic service with trained nurses, good ultrasound techniques for transperineal block, as we also provide transperineal biopsy service here. So we've developed a comprehensive portfolio of minimally invasive surgical techniques for BPH and the local anaesthetic. And the real joy is it's in your hands, the waiting lists are under your control. I'm not reliant on an anaesthetist or a theatre team or a theatre space. And as a result, what's often seen as a functional illness that doesn't have a time-sensitive treatment by management or clinical decision makers, we can move it into the outpatient setting where it's under our control. Patients are able to go home the same day, they're able to drive home in some sittings, there's no sedation, there's no IV access, it's purely ambulatory local anaesthetic, and our patients definitely prefer the lower risks. The outcomes are grossly the same as under general anaesthetic. The number of treatments delivered are the same, and the pain score is actually equivalent to having a small local anaesthetic procedure such as a skin lesion excision. On the whole, patients are very positive about the treatment. They feel they recover very quickly. They're aware of the treatment throughout. They're able to have a conversation with their consultant and other members of the team throughout the procedure. We don't feel like we compromise on the treatment delivery or surgical technique in any way. And there's a massive advantage of not having the risks of a general anaesthetic, a potential overnight stay, as well as the time it takes to go to theatre. So although they're anxious initially about the positioning and the procedure itself, overall their anxiety levels are much less. The general advice would be to look to offer it under general anaesthetic initially. Initially with your theatre team, you can make it a comfortable procedure for yourself. You can then bring your clinic team into theatre to learn it under general anaesthetic before doing it under local anaesthetic in theatre and then moving it towards the outpatient setting. I'm just taking you a little tour of our department where we practice our local anaesthetic BPH procedures. So just down here is our treatment room where we're fully set up for transperineal prostate biopsies, as well as all minimally invasive surgical techniques, Rezum or water vapour therapy. So this is just our preparation point, and this is just for the transperineal block, which is the first part of the procedure and is really the key part for performing it under local anaesthetic. So we're using our transperineal ultrasound probe, and we're using it with a fixed biopsy device. The patient's already had topical lidocaine, which was chilled down the urethra for about 10 minutes with a penile clamp just to keep it in position. Initial part, which is just a quick ultrasound. Alright, so just the ultrasound probe easing in at the moment. Just our prostate. So our prostate's around 50 grams that we're treating today. So what we're looking for is to identify where our lateral injections are going to go. Approximately this angle should reach the pedicles laterally beside the prostate on the patient's left, and then again on the opposite side. And we do two parts to the local anaesthetic internally. Got the external part first now, which is the skin block. So cold spray and just some 1% lidocaine with adrenaline. And the pre-existing markings show roughly where our tract will be, so as long as this part of skin is well infiltrated, it should be nicely numbed. We're just going back in with our transrectal ultrasound for the transperineal block, and we can see our prostate well outlined there with a clearly demarcated transitional zone in the centre, which is where we'll be aiming to treat. So the initial part is to hit the lateral pedicles. This is an adapted part of our technique where we also do an intraprostatic injection. And if you look on the top film, you should see the infiltration just within the transition zone. See the needle in, just abutting the prostate before injecting, and filling that space well. Preserve 1 ml of local anaesthetic to the transition zone on this side, and you can see on the bottom the needle is intraprostatic here for the second part of the injection. This is an office-based procedure essentially, but we're still trying to adhere to good theatre protocol. So the patient's had 3 chilled tubes of Instilligel. The nursing staff have prepared our Rezum device already. Nice clear view of the screen. Happy that everything's clicked into position and we've got a good view. So just get a nice clear view for us going in. You may feel your bladder getting a little bit full, sir. That's just us filling it up. If it gets too much, just let me know. Gentle look, we're approaching the prostate already, and we're in the bladder. So we've done our measurements. 1, 2, approximately 3 centimeters from bladder neck. So I'm expecting to do 2 treatments per side. I'm going to treat from the apex going towards the bladder neck. So we're facing away from the ejaculatory ducts. All right, sir, first treatment is starting, okay? You may feel a bit of a heat sensation. So first treatment's complete. Moving on approximately 1 centimeter. Second treatment on the patient's left. And there we are at bladder neck. We've got space for 1 more here without being too close to bladder neck. Patient doesn't really have a median lobe bulk, so I'm not going to deliver any median lobe treatment. I'm going to work to the other side now. And again, come to our apex, make sure we get a good view. And if I lose the view, I'm just going to come back to bladder neck and more conventionally treat coming antegrade. So first treatment on the right hand side. The difference under our local anaesthetic is we don't quite have the luxury of time and going back in and out many times to check. And then I want to deploy 1 more treatment closer to apex, apex here laterally. Last treatment coming up, sir. So this will be 3 treatments on each side and we're done. Performing it in the ambulatory setting has transformed my mindset. I think the waiting lists are shorter and the outcomes are really good. So I think my patients do well. I think they're pleased with the outcome. They are pleased that they recover more quickly. And they're certainly pleased that they have a very close relationship with their responsible consultant throughout their journey.